Well, hello there. My name is Christopher Starr. I'm from the Weill Cornell Medical Center, and this is the iTube Journal Club. And I'm very, very excited to have my friend Boris Malyugin here with me today, a name that most people have heard thanks to your ingenious design of the Malyugin ring. A lot of people mispronounce your name, and so did I just say it right?
Yeah, absolutely.
Close enough?
Absolutely.
And of course, Boris is from the Fyodorov Surgical Complex in Moscow, a world-renowned institution, a lot of innovation over the years. I was fortunate enough to be there recently at a fantastic meeting in Moscow. And so, Boris, I want you to tell us a little bit about, if you can recount the process of this great idea, taking this great idea that you had and turning it into a product that is used worldwide.
The idea comes from the lens, because we in Russia have the lens, which was, by the way, first in the world yellow lens with the yellow tinted optics. It was made from PMMA, and it has two closed haptic elements, and at the middle of each haptic element there was a small scroll, and from time to time it was unintentionally you can catch the capsule. As you remember, that time we were doing extra cap, and the capsule was cut in the envelope fashion. So to insert the lens, sometimes the lens goes into this, and that's why later on I was motivated to create capsulorhexis fixated IOL, which was the lens that was having three elements, and it was fixated in the capsulorhexis opening. In case when the capsule was broken and capsulorhexis was intact. And from that idea I came further and then developed the pupil expander.
Wow. And how long roughly did that take to get it? How many prototypes did you go through, and how did the design sort of change over time to what it is now?
Actually, we did a couple of prototypes and different models, and then it was an interesting story because I showed this in the film festival, ASCRS Film Festival, and later on I was engaged with MST, with Larry Lax, and we worked very closely together on doing the final products that you know well.
Yeah, which we all know. Now, there are a lot of people, and I got to admit that I am one of them, in whom have not really tried it yet. And part of that was just not really knowing exactly what to do, how to put it in, take it out. I know there are a lot of pearls. I was on a panel just yesterday, and everybody had a different way of approaching it. So what I want to know before I actually do it for the first time is what you do, because you're the guy. Any pearls for injecting it, taking it out? Do you do it manually? Do you use the injector? Which of the eyelets do you do first, etc.?
The device is very simple to use. That's why many people are attracted with this idea. Yeah. So you use your main incision. Right. First of all, I do prefer to inject intracameral lidocaine. Because when you manipulate it with the iris and operating under topical, it can be sensitive. Yeah. Then you fill anterior chamber with viscoelastic, but do not overfill, because when you're overfilling, you're actually pressing your iris to the lens capsule. Then you engage the ring from the holder, which is a ring is located in the holder, and you connect your injector to the holder and then retract the ring. And then when you insert the injector, you position its tip quite close to the iris margin, and then by pushing on the thumb button, the ring starts going out, and when it's closed, so you can easily catch the distal scroll with the ring. And usually when you are injecting slowly, you try to a little bit to go back with the injector while you're expelling the ring, so the ring will expand, and both lateral scrolls in most of the cases catches with the iris. So you have only one scroll to insert manually, which is the last one. I call it proximal scroll. Yeah. So to remove the injector. You have to be careful to remove it in the open, so the hook will not catching the proximal scroll. And then you can use either side port incision or the main incision and use manipulator. There is a special that is produced by MST, which is called EJC Malyugin ring manipulator, which is quite helpful. Alternatively, you can use Kuglen or Lester hook. Avoid Sinskey hook because a Sinskey hook has a sharp edge, and while manipulating, you can easily puncture the capsule, which you would like to avoid. And that is the end of the case. I mean, at the end of the first part of the story, because you have to remove the cataract and remove the ring. To remove the ring, I recommend to go for the distal scroll first. You have to disengage two contralateral scroll. Better to disengage the distal one because while disengaging, you can displace the ring a little bit away from the incision to expose the proximal scroll, and then it's quite easy to catch it. Put it on top of the iris, and then insert with the injector, catch it, and remove from the eye. The incision should be 2.2 millimeter, and when you are retracting the ring, to completely retract the ring inside the injector tube, when two lateral scrolls merge together, it's time to press with the side port instrument, so these lateral scrolls go directly inside the channel of the injector. There are some tricks, but they are quite intuitive, and you can, I think, while watching the video, one time you will see the video, and then it takes longer to explain than to use it actually.
And it actually now comes in a bigger. It was originally a six and a quarter.
6 1/4,
yeah.
And I still prefer it because I think it's quite universal, and I'm very happy with the technique that I use. But many surgeons many surgeons who use divide and conquer technique, when you need more space, more access to the lens, like bigger ring. The other case is IFIA syndrome. With this type of patients, the pupil can start bigger and then progressively constrict. So that's why bigger ring holds better the iris in place than the small one, of course.
Is the bigger one harder to put in or take out? Or?
Of course, there is a trade-off. There is a little bit more. It's more difficult to manipulate, specifically when you want to retrieve the proximal scroll. Sometimes it goes below the main incision, so you need to fish it out. But if the cornea diameter is normal, it's not a big issue. But the smaller eyes, that can be more tricky, but with experience, if you try 1-2 cases, then you will be a master of that.
Awesome. Boris, as always, this has been fantastic. I want to thank you. This information is very useful to me, and I'm sure a lot of our viewers. I want to thank you for watching. Thanks.